Okay. So, um, the main topic today we will be talking about, is embolization of genicular arteries and musculoskeletal embolization. So, when you think about osteoarthritis, that's a very important problem. Many people. I don't know how many people do you normally see with osteoarthritis every day, but according to the CDC, it looks about 30 million US adults are affected, which is actually like one third of the patients. One third of US adults have osteoarthritis, and the prevalence usually increases with age. 10% of patients are younger, and more than some when they are 75 and above. About 30% patients are affected with osteoarthritis. So the problem is not the osteoarthritis itself, the knee pain or joint any joint pain, but the patients are taking NSAIDs. They take Tylenol, they take ibuprofen. All these actually causes more trouble. These patients have the renal dysfunction, GI bleed, and according to the CDC, about 16,000 patients die because of the medications. And also, these patients also have problem with addiction from opiates because of the pain. And this is a new treatment that we are going to talk. Previously, there used to be a lot of other treatments available, but not everything is going to be helpful to postpone or avoid knee replacement. So mainly is genetics, environment, and biomechanical factors. And initially, the osteoarthritis affects mostly men initially, and then females catch up with osteoarthritis. And after age of 50, there is an equal incidence in both men and women. So we went through this etiology, aging, genetics, obesity, inflammation, and mechanical stress. You must have heard the word bone on bone. So normally there is a space between the bones, and once the osteoarthritis gets worse, the joint space narrows, and when it becomes narrow, sometimes they can also have gets, and that's the time there is no other treatment option other than getting the joint replaced. So this is a same patient. The right knee is normal and left knee has osteoarthritis. And you can have patients with the crooked knee with a genu varum. That's an angle. And once it becomes a stage where it's a lot of osteoarthritis, then there is not many options available. Almost 80% of patients come up with a treatment. Is initially they don't do any treatment. Maybe they do ice, elevation, or physical therapy. Then some patients take uh, medications to reduce the pain. They rub diclofenac gel, take ibuprofen, naproxen. Then they go to joint injection. And joint injection, they start giving corticosteroids, hyaluronic acid. Then they do gel injection. Everything has a high recurrence rate. Nothing is a long-term solution for these patients. But finally, they come up with a knee joint replacement. So this is like about 10 to 20% of patients. When they fail all these treatments, they go to knee replacement. Even with knee replacement, not everyone feels better after the knee replacement. They still continue to have pain in the knee. And so what is the solution here, for these patients? So the main in the past, they used to think that every patient who has osteoarthritis, it was considered as a wear and tear. But the new evidence shows that there's a low grade inflammation going on in the synovium. In the synovium, you have the chemokines, cytokines, in the metalloproteinase. Uh, all these actually causes this ongoing inflammation. That is the reason for the pain. And what happens is when you have enzymes which are being secreted, you can have the neovascularization or angiogenesis. These new vessels actually start maintaining the growth of unmyelinated sensory nerve fibers. This is nothing but just like if you think about like an electrical wire which has insulation. If you touch the electrical wire with insulation, you do not have a shock. But if you like touch a live wire with no insulation, it shocks. Same thing. That the pain is mainly because of this sensory nerve fibers which are being maintained by this new vessels. This is what we are going to be targeting to help a long-term relief. So when you think about these enzymes, what do they do is they not only causes this new nerve fiber growth, but also they damage the cartilage because it's an ongoing inflammation that causes the damage. So when you see this is directly the guidelines that we took from the American Association of Osteopathic Society. They actually they downgraded the most of the treatments currently available, like manual therapy, massage, laser treatment, acupuncture, nerve stimulation or nerve ablation, also like electromagnetic pulse wave therapy, extracorporeal shock wave therapy. Nothing, all these have been downgraded in the evidence. So these are all either not working or is just almost like a placebo. So the main concern, what is a vascular treatment available is this angiogenesis, which actually recruit all these macrophages and causes synovitis, and synovitis causes cartilage damage. So this is like a vicious cycle, which causes osteoarthritis and finally a damage to the cartilage and bones. That's what we are trying to avoid. And what we do is we actually do a score called WOMAC score, and this WOMAC score tells us what is bothering them and how much is the pain score. This is a score has been validated across all the osteopathic societies and all the rheumatoid society. So we need to do a WOMAC score. Higher the score, higher their pain, and higher their lifestyle problems. So this treatment has already almost, we know that in the US they always start late in all these treatments. So initially the treatment was started in Japan in 2017. So it's very, very new. It started in 2017. Okuno is the first interventional radiologist who started it. So he started using an agent called imipenem. And he used it. It's a single arm trial. There is no placebo. But what he found was that it was about a 50% reduction in WOMAC score, and it actually sustained for 2 years. It's very, very rare to have a treatment which sustains pain relief for 2 years. Most of the current treatments available, work for a month or two. And in US to get an approval, we need a randomized control trial. That's the only way we can get approved. It was approved last year, end of last year. So there were 2 randomized control trials, which was done, and it actually showed that there is a very good reduction in pain because in US it's only done recently. We only have 12 months to follow up. So when you see that, the pain reduction goes down and it is sustained for 12 months, and WOMAC score also goes down. So this is another score. They use visual analog score that we usually have this 10-point score, 1 to 10. That also, so they did both scores. It showed very good relief. And this is an MRI. So in MRI, when you do a contrast MRI, you can see the synovium is inflamed, and that is what is causing pain. So we are trying to find the artery which supplies the synovium, but not the joint. And we are injecting this either antibiotic, which is the imipenem, which is actually when you combine with the contrast, it becomes a small particle about size of 75 nanometers. And we also use permanent particle embosine, which is about 100 nanometers, but this does not bother the larger arteries which are supplying the joint. So when we inject this medicine into the artery supplying the synovium, it only targets the neovascularization, the smaller arteries, and not the bigger arteries. So this is an example where you see, actually, this is the joint, when you can see the joint behind, because we're using a DSA, and this is the popliteal artery. And this is the neovascularization. And patient can actually exactly point out the place where they have pain. And we inject the embolism particle or antibiotic into it, and the pain is gone. Most of the times, this blush or neovascularization, the pain is gone immediately. They have pain relief on the table, many patients. And some patients get pain relief in a month, but you have a definitely exact spot where the pain is. And this is a combination of all the papers together where you can see that patients with the mild to moderate osteoarthritis, this visual analog score, which is what says, like we say 1 to 10, you see about 8 is the baseline patients were having. And after treatment, you can see the score has reduced to 1.8, really a good score decrease. So patients were having who are taking NSAIDs. The 46 patients were taking NSAIDs, and then it decreased to 9 in 12 months. Patients who were getting injections, the hyaluronic acid injections, 39 patients, it decreased to 2. And patients who were receiving physical therapy, 39 became 2. So it is actually in 12 months, you can see almost everyone were able to have a nice pain relief, and not only pain relief, but also it actually make them go back to work. And this is for mild to moderate osteoarthritis. Even for patients with a severe osteoarthritis, where almost the joint is destroyed, you can see they also had a great pain relief. 10 patients to 3, 10 injections to 1, physical therapy to 1. So it actually works in both, but it works much better in the patients with not the joints are destroyed yet. Yeah, we know that any procedure we do, there is going to be side effects, but it's very, very little. The same kind of side effects for doing an angiogram or a heart cath. So there can be a small groin hematoma. Because we are using antibiotic, imipenem, patients can have diarrhea, or they can have the skin discoloration. The skin discoloration is mainly because we use a small particle size, like 75 nanometers to 100 nanometers. There are capillaries supplying the skin, so they can have some discoloration. What we do is, to avoid this, we put an ice on the top of the knee joint, so we could get these arteries constricted so that we can avoid this, and rashes from antibiotics. Some patients have like a transient numbness in the leg, which actually resolves in 5 to 14 days. So it's all very, very safe. So this is one of the patients we did, where we have we inject the angiogram. We take a small microcatheter into the artery, which is supplying the knee joint, and the patient can point out exactly where the pain is. See that blush or the neovascularization here? You're not actually targeting the big arteries here. It's the blush where you have the pain. So we inject either antibiotic or microsomes, and the pain is gone. So even if a patient does not have inflammation, you don't have this. So at least you're giving them a no, they're giving a pain relief. And once you cut down the blood supply, the new nerves which are having the pain, they don't have any more blood supply, and it dies. So that's how the pain relief is there. So the pain relief is because of that unmyelinated nerve fibers. The nerves are dead, so there's no more pain, and it does not affect the bone. So who can benefit from GAE treatment? Anyone who has failed physical therapy, medication or injection, and patients who aren't ready for knee replacement or do not want to have a knee replacement, and if there are any health risk that makes surgery risky. And young patients are very, very, who are very active and who want to delay knee replacement can have this. So this is how we actually do. I know the interventional cardiologists know how we do. We just get an IV in the groin. We normally use it under fluoro. We go and see where the artery is. We don't have to go through the groin, but we could even go through the foot artery. So that's the reason we do an ABI and arterial duplex, to make sure they have a 3-vessel runoff. So we can do this procedure through a small incision in the groin. We use a 4 French sheath, which is actually just same size as the IV that we do in the office to get the IV fluids. Either we can go through the groin, or we can go through the foot once we know if all arteries are open. That's the reason we do arterial duplex. So some patients can have a blockage in the arteries in the leg that can cause leg pain as well. So before we do any genicular artery embolization, we wanted to make sure they do not have a PAD. But we don't have to worry about if they have a PAD or not. We can fix that at the same time if they have a PAD. So once we have the sheath in the groin or in the leg, what we do is we actually move the wire down the popliteal artery, which is close to the knee joint, and the knee joint is supplied by 6 arteries. So we find exactly which artery is supplying that the pain area, and once we know, then we put ice on the top. Once the ice is there, then we go to that artery. You see that angry artery on the top, which is supplying the pain to the nerves which are supplying. So we put this antibiotic or this embolizing particle into it, and it only targets the neovascularization because this is so small. It goes and stays in the smaller vessels, not in the bigger arteries. It gets fleshed off in the bigger arteries, and once these particles go, they stay there permanently, and then it actually kills the new nerves which are supplying the pain. And once it's done, we remove the artery, so we remove the catheter, and the pain is almost immediately the patient gets pain relief. About 80% of patients have 50% pain relief at the end of 1 year. So once we remove the catheter, because it's a 4 French sheath, we just hold the artery, and then we have the problem is solved. So mostly it's a simple non-surgical procedure, and it's done in the office. You can go home the same day, and you don't have to go have to have you can avoid knee replacement, and there's a low chance of any complications. It has proven to reduce knee pain, and the recovery time is much shorter than the surgery. So that is a very important thing. So you also need to know that this can be done in patients with tennis elbow, jumper's knee, Achilles tendonitis, wrist joint pain, hip joint pain, or any stress fractures. It can be done. And mostly, if you think about it, nowadays, young patients who are like players have a lot of knee pain. They don't even go back to our pain. Some people even avoid playing because of all the injury. And nowadays we find which artery to fix. We go through that artery. So we can do any arteries. And this is the worst thing that you can have. Now, almost everyone is playing like a pickleball, and you are having this epicondylitis and pain. This can be fixed. And it's so simple. We go through the radial artery and find the exact place where they have the pain, the neovascularization, and inject the embolizine. And these patients can resume playing the next day. And same thing if a patient has a shoulder pain, rotator cuff injury. And so you find the spot where they have this blush, and that's the target region. And then you inject either imipenem or the embolizine, and the pain is immediately relieved. And so this is the next one, is Achilles tendonitis. So you see the MRI, and they have this inflammation. So we find exactly where this inflammation is there, and then inject this imipenem or the embolizine, and it helps pain relief. So this has been done in any inflamed joint that we could do. So this is a kind of a very simple procedure. It does not take more than half an hour to an hour in the office, and patient can resume playing And so that's what it is. You can ask me questions, if you have any that you need to do. Hmm. Hmm. So first thing is, we need to know exactly which artery is supplying the inflammation. So once we know the area which is there, so because we have six arteries supplying the knee joint, a patient may come with a pain inside the knee, which is like a medial part of the knee, and we may have targeted that. And maybe in future, patient has a pain in a different region. So, and but the artery which supplies the pain area, which we target, it is almost never coming back in that same artery because we have done. Yeah. But yes, it can be in another spot. Correct. So the WOMAC score, we are not looking for anything in any baseline or anything, but it is to see how bad is the score. Higher the score, more severe the pain and lifestyle limiting symptoms. Usually the nurses can go over the WOMAC score before they come, and if it is more than 50, it is considered really very high. But many patients get score below 20 after we treat. It's not, there's no number. I'm just saying that it's going to be, higher the number, worse the symptoms are. It's so when you do the WOMAC score, it gives a 50%, 60%. That's a percentage. I'm talking about percentage, 50%. Correct. So severe is um, is mainly is for patients who have, what I was talking about is if a bone marrow is destroyed, it's not the pain severity. More pain, better relief. But if a bone marrow is destroyed, yes, it does not work that much when compared to patients with no bone marrow destruction or joint destruction. But still, if they have inflammation, it's going to work because you saw patients who are taking like 10 NSAIDs, it went to two. So, okay, yeah. But yeah, correct. Higher the better, but there's no real. So score 46 is different from, there's a percentage there. So, so you see the patients, really went from 46 to 9, but you're right, in severe, still there's a very dramatic reduction in pain. You can see that also. And I think this is the WOMAC score. When you see, I think they are talking about 0 to 100 is the, so that is a at least it reduces by half the WOMAC score. Joint pain, which is, really having a high WOMAC score. Number two is if they have, tried NSAIDs and all the pain relief. And the injections, yes or no, depends on, how severe the symptoms are. Some patients may not want injections at all. I have seen some patients. But if they had an injection and failed, yes, they will be the one that we can ask them if they would like to have a relief, which is much more sustained than an injection which only works for 1 month to 2 months. And also, the studies have shown, but they have not really talked about this. Mainly is when we do the genicular artery embolization or embolization of anywhere, when they have synovitis, and there is a joint destruction. Once we have treated, actually, the space between the joint actually increases, but it's not really studied for that. But the joint space have come back after doing the treatment with a GAE, which may even avoid them from having a knee surgery for future. But but they did not have like a randomized control trial on that. But the joint space have actually increased after the procedure. So we could do antegrade stick or regular, retrograde or pedal. So antegrade is much better if it's a small patient, and if I do both antegrade for thinner patients, and if patients are overweight, either do pedal or other go in the opposite groin and go up and over. So so we normally do just a regular like any angle catheter, like a burn catheter, and go down the popliteal artery and take a picture and find which artery is supplying the pain. And after that, you get a microcatheter and a 014 wire and target that artery and take a picture of the artery. So there are six arteries, which is the one is a descending. I didn't have the diagram, but there are three on the middle side and three on the right on the lateral side. So you need to what we do is we mark the skin exactly where the pain is, and then once we mark the skin, and we find just mark the skin where the pain is, so we can definitely target. We know exactly which artery is supplying that place, and go and selectively catheterize that genicular artery and inject it, and you'll find exactly where is the pain. And then once you find it, then you inject until the blush goes away, and still you preserve the bigger arteries. Correct. No, yeah. So what I do is I select the artery first with angle catheter, then do as distal as possible, because sometimes it's not like this. So what I do is, like, say if this is the vessel there I want target, I don't want to just do somewhere here. So I put the microcatheter until the tip here, and then I put the catheter, then get the microcatheter into the vessel until the distal area, and then I inject it. So you don't have to inject if it is all normal on this side. So if it's just diffuse like this, you don't have to go down. Sometimes it's not diffuse, it may be just only one spot. Then you go more selective. Yeah, so that's a main thing is, and also we need to tell the patients, that is, it's not like 100% that, it is going to be what the studies have shown that at the end of 2 years of current studies have shown that about 80% of patients have 50% pain relief, sustained pain relief for 2 years. So that is the data we have currently. Okay, guys. Okay, guys. Oh, correct. The insurance covers this. Yeah. So now, because we have a randomized control trial, the insurance covers this. But yeah, they should, we should document that patient is suffering from pain and tried NSAIDs and injections, yes or no, and patient does have pain and needs pain relief and does not want a joint replacement, and any joint. Correct, correct. Yeah, that's other great thing is NSAIDs are contraindicated for heart disease, and patients cannot take NSAIDs, and this may be a very good. The main thing is insurances are not getting easier, but you need to really write in a note telling why this patient is still suffering. One thing is patients not able to take NSAIDs because of the heart disease, because they cannot take NSAIDs if they have a coronary artery disease. And second thing is, it is really bothering her lifestyle, and they are taking off from work and they are missing days. Those are the things we can also. So the patient, insurance will be happy to do a procedure which will avoid knee replacement, which is more expensive for the insurance. Two, it is going to put the patient at a higher risk for surgery, anesthesia complications, deep vein thrombosis, and physical therapy after that, multiple days of missing work. And even with knee replacement, not everyone is going to get pain relief. So those are the reasons, now insurances are covering this procedure. Any other question? Okay, but thanks. Thank you all. Bye.